Dark circles involving the lower eyelid skin or around the eye are a source of great emotional upheaval in patients. And there are many patients who come to me who are very distressed about this pigment and how to treat it. Today, I'm going to discuss with Dr. Daniel Friedman, a dermatologist from Austin, Texas, his latest approaches to treating dark circles. What does a dark circle mean to a patient to begin with?
Yeah, it's a great question. I think the number one thing is that most patients don't really understand what is going on and why their dark circle has developed. So the first thing that I do is I look at the area, I move the tissues around, I judge how much pigment and blood vessels and volume and tissue laxity, loosening of the tissue are playing a role. That's the most important thing, because we get consults over the phone. I want to come in for dark circles. That's meaningless, right? You have no idea what is going on. So the first thing I do is it more pigment, red or brown, or is it actually related to shifting of the tissues and volume related problems? And so then that gives me a lot more information about where to go from there. The number one thing that sorry, well, you interrupt me.
No, go ahead. Keep going. I want to hear your thoughts.
And for you as a surgeon, and for me as someone who doesn't do oculoplastics or facial plastics, the number one thing I ask patients when it is an issue related to aging is surgery an option? Because if surgery is an option, that's always going to be the best option for them. If surgery is not an option, then I feel like there are things we can do to improve the area and hide the problem. But if they have prolapse of the fat, where the fat is moving forward in this area, I can't do anything non-surgically to push that back or get rid of that forward moving process. But I can do something to hide it.
Yeah, but in my practice, of course, because I do surgery, surgery is really not the option in when I see a patient with dark circles most of the time. Now, maybe we're defining dark circles a little differently. I don't know,
Sure.
maybe. But I'm talking about primarily, very commonly, either people of Hispanic or Southeast Asian descent who have a particular ethnic propensity to form dark pigmentation of their lower eyelid skin or periorbital skin. And these are really, really difficult problems. I don't think they're easily remedied with surgery, frankly. I understand what you're saying. I understand there's volume issues and there's bulges of fat, and that people perceive the dark circle as being something below the bulge of the fat.
Right.
But I'm talking about pig on the skin per se. That's what I'm most concerned about in terms of the difficulty of treating those patients.
And you can imagine if we have maybe some lack of clarity as to what a dark circle is, you can imagine patients have absolutely no understanding what a dark circle is. So yeah, those are, in layman's terms, like real dark circles, right? It's an actual... It's an actual dark circle.
Right.
And yes,
Exactly.
Often genetic, often ethnically predisposed, where certain people, often of Southeast Asian descent, some African American or African descent, they have a higher risk of that area turning dark. Why it turns dark, no one's really sure. Sometimes it could be just purely melanin. Sometimes it could be related to chronic stasis, which means that those vessels there leak fluid. It leaks out some iron and other materials, other chemicals that are then staining the area. So there's no perfect way of knowing what that is.
Okay,
Without a biopsy.
but let's say, I understand that, but very often I see like people who are of Indian descent,
Sure.
and they have very, very dark circles under their eyelids. And my question is, first of all, is that increased melanin? Is there actually? I was on the, my understanding is there isn't an increase in melanocytic cells. Is that true or false?
It's most likely true. Where you tend to see an increase in melanocytic cells are in what we call dermal melanocytoses, which is
Right.
an increase of melanin producing cells, often in the second layer of skin. And a lot of times that's genetic or just from bad luck. But in that area of the lower eyelid, it is, number one, not an area that's commonly biopsied. So I don't think there's that much evidence to counter your claim, or the claim that there isn't an increase in melanocytes. But thinking of it logically as a dermatologist, it seems like it's most likely just an increase in melanin. And so the treatment is to try to reduce the amount of melanin in the area. Now, you have patients who are naturally darker skinned, so you have to be much more careful with devices and procedures. I always tell people, we're not racist, but these lasers often are, right? They are your pigment can be very sensitive to certain lasers, so we have to think ahead and plan and use the right kind of procedures so we don't cause a new problem trying to fix an existing problem.
I got it. So my next question to you is, first of all, I think it's important, you brought up an important point, and I think that is some of the pigment can be superficial,
Right.
relatively superficial, and it may be, as you said, this iron. The iron molecule is inside of a hemoglobin molecule, which is
Right.
in the red blood cells.
Yeah.
And those iron molecules, just like iron on a chair, can sort of rust
Yeah.
and become brown in the skin from leaching out of the vessels.
Yeah,
I
the
don't see that. Actually, I don't see that very often, to be honest with you. I don't see that very often, but I'm going to stop you there. I'm sorry, I'm going to interrupt you.
No
But I
worries.
want to know how, as an expert in lower eyelid dark circles, how do you treat hemosiderin, which is this pigmented iron in the skin? How do you approach that?
The one thing I was going to say before I answer your excellent question is the easiest way for people to know what that looks like is when they get a bruise and it starts turning kind of brownish and yellowish. That is hemosiderin.
Okay.
Now, in some areas, especially very thin-skinned areas like the lower eyelid, the skin is so thin that you end up seeing that leftover iron in there. How do you treat it? The best option is with a laser that, number one, can reach that second layer of skin. It has to be a longer wavelength. And number two, it has to be able to heat it up enough. These are very small particles. They're similar to tattoo particles. And so you need a very fast pulse of light. So you can't use IPL or very long pulse durations, the duration of how long that light is emitted. So you need a device like a nanosecond or picosecond Q-switch laser. People who've had tattoos removed will know what a Q-switch or pico laser is.
Right.
The only issue in this area is if there is no bone there, I would not use one of those lasers because the wavelength is long enough that there have been reports of people getting that done inside the bony rim of the eye and developing a blind spot. So that is the risk. Yeah. So if I can pull the skin down enough that I can feel bone underneath where I'll be treating, then it is safe. But even with a metal eye shield, like we will put for eye procedures, it's still not completely safe. And most people do not want to take the risk. But like you said, that part of the problem is pretty rare. Where I tend to see that is people, I stretch their eyelid, which I always do when I'm judging dark circles, and if it's just covered in vessels, just lots and lots and lots of vessels, I have a higher, predisposition to target that with a pico laser, at least in part, because a lot of vessels means a lot of iron could be leaking out of those vessels, which are very fragile, and the skin there is very fragile. So I have to at least keep that in mind. But like we talked about before, people of Indian descent or Southeast Asian descent, 95% of the time it is really just melanin, brown pigment and superficial.
So, but wait a minute, is it superficial or is it in the dermis? It's in the deeper layer, isn't it not?
Well, it's primarily going to be epidermal.
Epidermal?
Yeah. Now, if you can get leaching of melanin over time into the dermis. Any condition where you ramp up the production of melanin enough, even without trauma, can leach some of that melanin into the second layer of skin. But this is going to be primarily an epidermal issue. If it wasn't, the kind of lasers that I typically use for this condition, which are devices like Fraxel or superficial peels, wouldn't be able to treat it. There's just no possible way they would go deep enough, even with a very thin-skinned area like the lower eyelids or upper eyelids.
So in your paper with Dr. Goldman as a co-author, you did outline a bunch of types of lasers that are Q-switch lasers.
Right.
What's called Q-switch lasers, and you might want to define what Q-switch lasers are for the audience.
It's complicated.
But I'm curious, after you do define that, you did mention Q-switched ruby lasers, Q-switched alexandrite lasers, neodymium YAG lasers.
Right.
How do they all fit into the paradigm of treatment? When do you go for Q-switch ruby, for instance, and explain what a Q-switch is?
Sure. Q-switch is quality switched. And so if you can imagine you had a chamber with balls moving back and forth over and over, that is the light that is being generated inside a chamber. And then you open a little window which allows the light to leave, and you close it very quickly. We're talking about millionths or billionths of a second. That is called quality switching. Because if it's in the seconds or milliseconds range, which is much, much longer, that is called long pulsing or non-Q switched. So that is what all that means. These are very, very short pulses. Why you would use one laser over another depends on a lot of different issues. One is how deep is the pigment, and also how dark is the skin that you're treating. If you're using a ruby laser, which is in the 690, 670, somewhere in that range, you want
nanometer. That's a wavelength. That's a wavelength,
exactly.
Right?
So these are relatively short wavelengths. Visible light is 400 to 700. So this is still in the visible light range, but it's more in the yellowish light spectrum. And so getting closer to green. And this is really only a laser you'd want to use on people with very light skin because it actually targets background skin very, very well. So for age-related brown spots on the face on very light-skinned people, solar lentigines or senile lentigines, as they used to call them, or liver spots, ruby may be the best option. Because it targets that brown very well with much lower risk than like a 532 wavelength, which is exceptionally good at treating brown, but sometimes too good. Then you can go.
Well, it's too good in the sense that it might depigment the natural melanin, the natural pigmented cells in your skin. You may end up with a kind of a white spot.
And even in people with somewhat lighter skin, the 532 does have, of all these Q-switch lasers, has the highest risk of what we coin PIH, post-inflammatory hyperpigmentation, which is a reaction of the skin in response to trauma where it makes more pigment. And so the more aggressive it is against treating the pigment, the higher the risk your skin may just fight back and start making more pigment in response. Now, that is a temporary problem. It does go away on its own, but it is a big nuisance and a figurative headache for everybody. So we try to avoid that as much as possible. As you go farther down the range of wavelengths to alexandrite, which is 755, or 1064, which is Nd:YAG, Those wavelengths go deeper and deeper, so they are better at targeting both epidermal and dermal second layer of skin pigment, but also are much safer on background skin color because your melanin really only absorbs somewhere in the 400 to 700 to maybe 800 range. And past that point, the amount of light it absorbs drops off precipitously. So you can target brown with 1064, but it only tends to target the excess brown, what is above normal.
Yeah, that's a little confusing to me because obviously there's just for our listeners, there's a photoselective aspect to lasers, meaning like there's a certain limit on where the best absorption of light occurs based on a color of the target, whether it's red or brown. But I don't understand if you can use a laser outside of that peak absorption, like at 1064.
Right.
I don't understand how that addresses the pigment. How does that do that?
Yeah, it is a confusing issue. You're looking at.
Thank you.
Trust me, I've written many papers on like the photophysical background of some of these things, and it is not an easy topic. It's essentially so melanin has absorption. Or any target, what we call a chromophore, which is a target that has some color to it, has peaks of absorption. And when you see some of these absorption curves, you will see these peaks and then valleys, peaks and valleys, peaks and valleys. So melanin is somewhat interesting in that it's almost a straight line, which is very different from water and hemoglobin and other chromophores. And so past a certain point, it's not even truly registered in the absorption curve because it's so low. So yes, with enough trauma, the 1064 wavelength will treat brown. It just does so very poorly, which is
Is it? I'm going to ask you a question here. I'm sorry to interrupt you.
No, please.
I apologize, but I'm going to ask you: is that a photoacoustic effect? Does that mean like it actually has a mechanical effect on the melanin at that point, or is it actually being attracted to the melanin?
Well, it's both. It's primarily photothermal. So and that means that the light is actually being absorbed, it heats up, and then damages it. But all Q-switch lasers have some kind of photoacoustic effect, which means the absorption of light causes some mechanical, almost shearing force on those particles that is not heat related. Pico lasers tend to have more photoacoustic effect than nanosecond lasers because a pico pulse duration is much faster than a nanosecond pulse duration. So the way I explain it when I give talks is imagine two pots on the same sized fire. One pot is very tiny and one pot, sorry I'm hitting my microphone, is like 100 times the size. You can imagine how much more damage that flame is going to create on that very, very tiny pot. The water is going to boil over almost instantly, while that giant pot it takes much more time to cause kind of buildup of heat. So that's what's happening. It's the buildup of heat is so sudden that it also causes a lot of mechanical shearing forces on the pigment.
Okay. So I'm sorry, I'm going to ask you to go back now and say, how is this 1064 working at the, even though it's outside the peak range? How is that working?
Because there's still some range there. It doesn't work as well, but we know for sure when you have exogenous pigment, which means pigment that has been introduced into the area, or excesses of pigment, there is enough matter there that even though its
like
absorption is small,
exactly. Like a tattoo.
That's what I mean by exogenous. Exactly right. Yeah. Or hemosiderin from trauma, from really excessive bruising in the past. When you do eyelid surgery, some people will get staining in that area. So when you have enough of that chromophore, enough of that target, you still get some absorption. It's just low. So a lot of times we are trying to judge what is the color of the skin that we're dealing with, how deep is the pigment, and how much risk are we taking. And in that way, I try to kind of determine what is the best wavelength for this patient. Obviously, a 755 is going to be ideal for hemosiderin, but if their skin color is really, really dark, I don't want to risk destroying their normal skin color in the process.
I got it. I understand. So again, here's the Southeast Asian patient coming into your office.
Right.
She's very distressed by her
Right.
pigmentation on her lower lid. She looks like an owl, and I don't mean that in a derogatory way.
Sure.
And she is desperate to get treatment. And what are you offering her? Tell me how you're approaching this. I don't think it's superficial, frankly. I don't think it's so easy to knock off that pigment so superficially. But tell me how you do it.
Well, treating it and easy should not be in the same sentence. I'm not saying regardless of where the pigment is or what it is, the treatments are never easy. This is never, ever a one and done kind of treatment. This is usually many rounds over a long period of time. And then each time we do it, we're getting closer and closer. So again, it depends on where it is and what I feel is safe for the patient. When we're dealing with actual eyelid, where there's no more bony contact, even though I may want to use a pico laser, I don't use a pico laser there. I use something that will target brown by peeling off the layers where the brown tends to reside. And the best option for that tends to be a laser either like Fraxel, which I feel is the world's most precise peel. It's just peeling off those layers of brown, or a chemical peel. But and there's two schools of thought. Some people love peels, some people love lasers. I feel that in an expert's hands who's used peels for 40 years, a peel is extremely safe. But it's very easy to undertreat or overtreat. If you're using a glycolic acid peel, which is the mildest form of peeling, then the risks are very low. But if you're using a TCA peel, which can do some real damage in someone who's not experienced using them, I feel that Fraxel or something along those lines, I have no relationship with Solta Medical, but I feel that it is the safest for those patients and really controls the amount of downtime and minimizes the amount of risk with their typically dark background skin.
Yeah. But again, I don't mean to keep putting you in the hot spot, but I have a Fraxel, and I have experience with chemical peels.
Sure.
And I agree with you. I feel in my hands, Fraxel is more precise than a chemical peel.
Oh, absolutely.
I can judge the depth of layer removal to a better extent, and I think it's a little more controlled.
Right.
But again, I'm a little frustrated that we're really dealing with that dark-skinned patient again. I feel that the pigment is deeper, and I feel like the Fraxel is not really getting down to the level of the pigmentation that I really want to get to. I know you're afraid of the pico. By the way, my question is, I'm jumping around a little bit, but when you say you can't use a pico on the soft part of your eyelid,
well, you can.
Doesn't the light? It's very alarming to hear that the people got some visual side effects from the laser that was misused, but I'm confused. Why isn't the light diffusing through this layer of skin? In other words, the light should scatter. It should not be. It should not be like a single beam of laser light. And yet they're getting damage back there, aren't they?
Well, it does scatter.
Potentially.
It does scatter. Absolutely. Thankfully, I've never had that issue in any of my patients. I hope no one ever does. But there have been reports of people using metal eye shields and treating eyelids or areas where there is no bony contact and getting blind spots. It is most likely an unbelievably low risk. But I tell people it is a non-zero risk where I can't tell you that this isn't going to happen. If you're comfortable with that non-zero risk, just like getting into a car has a non-zero risk of you getting into a life-threatening car accident, you have to judge what that is, how much that risk means to you. Now, the other thing, going back to your previous statement, is yes, it is definitely possible the pigment is going into the dermis, but as you know, the skin here in the eyelid is so thin. By the time you're like at a millimeter, you can hit fat, like a millimeter and a half. These kind of lasers, even the Fraxel laser, can go down a half millimeter, like 3/4 of a millimeter with no problem. So even if you told me the pigment was all dermal in the eyelid itself, to me that would be relatively, not completely, but relatively meaningless, in that I still feel the laser would be able to improve it, while if you were dealing with the same kind of dermal pigment on the back, or now the dermis can be like many millimeters in depth, that's a very different story, because you're going to be treating epidermis and epidermis only with the Fraxel, and so that's not going to be efficient. But in the lower eyelids, thankfully, because the skin is so thin, I still feel it can help.
Okay. Now, you didn't mention in your paper much about chemical treatments.
Right.
And you have a little bit of a bias. You're trained in lasers, and you're a dermatologist. But I want to know, does Cispera, which is histamine, and does kojic acid, and does a lot of other topical medications like hydroquinone, really, where does this fit into the paradigm of treatment of lower lid dark circles?
Sure. And the goal of our paper, just so you don't think I'm 100% biased, although I do love laser treatments, was to discuss primarily laser treatments, not to disparage or overlook chemical peels or products that have chemicals in them, because they are still effective and can be valuable. Where I find, the first thing that I find is very important in people with darker skin is using something to ensure that the risk of PIH, the post-inflammatory hyperpigmentation, which can happen from any device, although very low with Fraxel or certain procedures like that, that doesn't happen. So we do put them on something with either hydroquinone or kojic acid or vitamin C, just to ensure that we minimize pigment production and help with skin turnover in the area. But chemical peels can be extremely effective. It's really using chemicals that you are comfortable using, or products that you are comfortable using, and having patients use them properly if they're using them at home. But there are numerous papers that I can recall over the years looking at combination products for at-home use of dark circles, in-office peeling of dark circles, and patients can absolutely get improvement. So in no way am I saying that peels are inferior to lasers. To the best of my knowledge, there are very few, if any, good comparative studies, split lower eyelids comparing one to the other, because it's an area that, even though it's commonly done, I don't know. I'm not sure why there isn't more research into that kind of treatment. Maybe it's just an area that a lot of providers may not be comfortable treating, just because it's close to the eye, it's very sensitive skin, and so that might be playing
It's a
role.
common problem, though. It's very common.
Very common.
So do you have any treatment paradigms for medications? Do you have any preference for hydroquinone with the Kopelman formula, which is a steroid mixed with retin A and hydroquinone, or do you? I've been leaning towards cysteamine, Cispera, which is a commercial name for that product, or I've been using kojic acid along with some other mixtures and so forth, and I've gotten some okay results. I can't say they're spectacular.
Right.
And the question is, do you use these in combination with the lasers, or can you use them standalone, or what's your approach?
Yeah, sometimes it depends on what the patients want. So if they're coming in saying, I want something that I can use at home, I don't want to do in-office treatments, then that takes our discussion down a different path. I've typically used, and there's a lot of different products on the market, as you know, and everyone has their own preference. And I have a feeling like with wound care, there's a lot of different products that you can use, and the results may be somewhat similar between all of them. But I like using either hydroquinone or hydroquinone with kojic acid. I don't tend to use a lot of Kligman formula because a lot of people find the tretinoin to be irritating, especially in the lower eyelid area. Even on much thicker skin, it can be irritating. So I've kind of used hydroquinone or hydroquinone with kojic acid. But
4%? 4%, or do you go higher?
I
You
usually
don't go higher.
No, not on the lower eyelid, because even that amount of hydroquinone alone can be irritating, and I don't want to ensure that we absorb it into the eye, although I doubt it could really do any damage. We just don't know. So I have them put just very light layer. Less is more in this area. It's very thin skin. You don't need a lot on there. And some people want to do everything. So most of the time, especially if they're darker skin, I will put them on something initially, one of these products, something with hydroquinone, have them use it for between 2 to 4 weeks, and then I have them do some form of in-office procedure. So when I'm doing Fraxel on the lower eyelid, I'm still treating fairly conservatively. I'm not looking to take off all the skin of their lower eyelid. I'm probably treating somewhere in the range of 30 to 40% of the settings that I might use on other parts of the face.
I got it. So you're pretty conservative. So you think
At
like
least for the first round.
Sequential conservative treatments over time, it gets you where you want to go. Is that correct?
Yeah, you learn quickly with lasers that going for the gold, especially in people of Southeast Asian descent, it's wrought with headaches. And a lot of times being more conservative and gentle carries a lot less risk of side effects. And in the long term, people will be happy, because the worst thing you can do is try to treat brown and then cause more brown in its place. They are livid, you're just upset, and nobody's won at that point. And it takes months for them to get back to where we started, and it's just a lot of frustration.
How about tranexamic acid?
Yeah,
Have you tried that
acid,
in terms of injecting it into pigment?
There are reports that it can help with post-inflammatory hyperpigmentation, pigment caused by procedures that is almost entirely dermal, so second layer of skin. It can help with hemosiderin, and it does phenomenally with hemosiderin, probably better than anything else.
Really?
Yeah. Tranexamic acid has excellent ability of breaking down hemoglobin and hemosiderin compounds.
Okay.
I haven't done much injection, although multiple colleagues of mine have, and they feel that it can be very helpful. There have been some reports in the people that I know injected of stasis, like lymphatic collection in the areas, almost like the trauma of the injection or the trauma of the tranexamic acid causes a little bit of fluid buildup, which can take time to go away. But other than that, it's fairly low risk. And in people that have resistant pigment, it may be worth a try.
Okay, that's very good. Well, I think we've covered the subject pretty well, and I appreciate your expertise and your conservative approach, I call it, because I think it is conservative, but I think you've learned to avoid complications.
Yeah.
And which we all want to avoid. And, it's very insightful because, these are problems we deal with every day, and they're not, we either can ignore them or we can try to address them. And very often plastic surgeons like myself ignore them. They don't really appreciate the subtleties of dark circles. I think that they look upon them almost like as one entity. And I think that what you and Dr. Goldman outlined, and which I've always believed in too, that there's a lot of diagnostic evaluation that must go into deciding whether or not it's a volume problem, meaning there's a loss of volume and shadowing effect,
Right.
or whether there is actually pigmentation and what level that pigmentation is, and as well as the ethnicity of the patient in terms of avoiding complications. So I appreciate your contribution to the literature and
Thank you.
also your wise advice now.